Welcome to this Peer Voice activity. To access the entire activity, including supporting material, go to www.peervoice.com/gsd. This activity is supported by an independent educational grant from Tayo Oncology Incorporated.
Hello, I am Marwan Faki from City of Hope Comprehensive Cancer Center in Duarte, California. Welcome to this activity, Making a Difference in Refractory Metastatic Colorectal Cancer, Practical Strategies to Positively Impact the Patient Journey Across Practice Settings. Managing metastatic colorectal cancer is complex. Beyond timely detection, strategic sequencing, and a coordinated team, clinicians must also navigate later line treatments, shared decision-making, and adverse event management, all while preserving quality of life. Today, through the lens of a lived experience with our patient advocate, we will discuss how to enhance patient-centered strategies, implement effective multidisciplinary management, and ensure continuity of care. I am pleased to be joined by our patient advocate, Jenna Scott, and my dear friend and colleague, Dr. Aparna Parikh, from Massachusetts General Brigham Cancer Center and Harvard Medical School, Boston, Massachusetts. Approximately 50% of patients with colorectal cancer present or develop metastatic disease. Metastatic colorectal cancer continues to have a poor 5-year survival rate of only approximately 15%. Although more patients now reach third line and beyond, there is still a critical need for early identification of progression and strategic sequencing to optimize outcomes. With that in mind, let's turn to Jenna's story to see what this means in practice. Jenna, can you please share your story with us?
Thank you, Dr. Faki. My cancer journey began when I was about 7 to 8 months pregnant with my first child. At the time, I experienced severe abdominal pain, rectal bleeding, nausea, and vomiting. These symptoms were attributed to late-stage pregnancy, and no further evaluation was done. Fast forward, my baby was born happy and healthy, but about a year later, shortly after his first birthday, I was diagnosed with stage 4 colon cancer with liver metastases. Looking back, I had experienced rapid postpartum weight loss, which I later learned can be a warning sign. At age 31, I was referred to a gastroenterologist who recommended a colonoscopy despite my age. The procedure confirmed the diagnosis of colon cancer.
Thank you, Jenna, for sharing that. Your experience really highlights how delays in diagnosis can impact outcomes and why timely evaluation is so critical here. And thank you for your courage to coming forward and being a patient advocate here. I think putting the spotlight on early diagnosis and taking symptoms seriously in this situation is extremely important. The more opportunities we have to identify cancer earlier, the better it is for our patients. I want to move on here to Dr. Parikh. Dr. Parikh, what practical strategies do you see in your clinic to detect progression early in patients with metastatic colorectal cancer?
Thanks so much for having me. And Jenna, thanks again for sharing your story with us. So currently in clinical practice for patients that are living with metastatic colorectal cancer, we get baseline imaging to assess the disease burden. Along with baseline imaging, we are also doing labs. We use tests often such as CEA, which is a tumor marker that some patients express, not every patient expresses. We also increasingly, in some scenarios, might use circulating tumor DNA. And when we start a treatment, we have that baseline information, and that baseline information really helps guide us in the future as patients are getting their therapy, allows us to assess, along with clinical symptoms, how a patient is deriving benefit or, on the converse, if they're not deriving benefit from a therapy. So in the metastatic setting, we typically tend to see patients for a treatment. Our practice is every 2 weeks if they're getting a 2-week therapy. I know some places will do even 4 weeks if everything is going well. And then we get tumor markers monthly. And we like to see a trend going down in the tumor markers. And then we get CAT scans, again, depending on the burden of disease, every couple of months, so 2 to 3 months for a patient with metastatic disease. And I think putting all of those factors together, along with how a patient is tolerating treatment and if they are having symptoms from their cancer, how those symptoms are progressing, allows us to assess benefit or lack thereof from a therapy. So, Dr. Faki, I think building on that, how do you approach response assessment and particularly performance status as you monitor your patients over time?
Yeah, I think as we all know, and as highlighted by Jenna earlier, we obviously want the best for our patients. We're always thinking about cure, right, for any patient. But at times we understand also this is a systemic disease where we are in it for the long run. And when we're in it for the long run, we have to address all the symptoms that patients have. We have to address their goals, how to be able to continue to live with cancer, not necessarily to live to get treatment. And so I think at the center of this would be symptom management, addressing comorbidities that may affect also tolerance to treatment. Um, we take things seriously. If there's significant diarrhea or moderate diarrhea, there may be a need for a dose reduction, dose adjustment. You cannot tell a patient, well, that's how it is. You have to live with your diarrhea. And that applies to all types of toxicities that we see across, the cytotoxic therapies or targeted therapies that we see. Each agent has its particular side effect that has to be managed. Intermittently, sometimes there's a need for breaks to allow the patients to take a breather. And those have to be factored in discussion with patients. We do involve our supportive care program. If the disease or cancer is advanced and is causing symptoms such as, pain or other side effects related to, the chemotherapy itself, you may have to involve some specialists or subspecialists in the consultants in the care of patients. I think palliative care, supportive care is important. And when we say palliative care, it does not mean that we are at the end. It means that we are bringing a service that helps the patient, continue their treatment with appropriate support for their symptoms. That supportive care and palliative care service may include nutritionists, physical therapy, psychology, psychiatry sometimes. All of these are important in the management of patients.
Right. And from my experience, staying well enough to continue treatment, ongoing treatment really made a difference in my journey and the quality of life that I knew I wanted to have versus the quality of life that on paper you read most patients experience after they've started treatment and have been on it for a long time.
Thank you, Jenna. That's such a great point. Moving forward, Dr. Parikh, how early should we be planning next line therapy in metastatic colorectal cancer? When do you start thinking about the next treatment? And what factors guide that planning?
So I think about the patient journey in totality at the time of meeting the patient, and so I'm not waiting till progression to sort of think around what that second line treatment might be. So at the outset, with every patient, you're looking at disease burden. Actually, taking one step back, as Dr. Faki said, for any patient walking in the door with metastatic disease, you're thinking about, is there a path towards cure? And what is it going to take to get to that path towards cure? Assuming that you're not on a curative path, we look at these features such as the tumor molecular profiling, easily or quickly assessing MSI high status, KRAS status, BRAF status. And that really helps me get a map as I go forward along with the patient, trying to think about where the patient's journey may take them. We think about the amount of disease burden, where the disease burden is. All of those things factor into to the treatment journey that patient will be on. We consider things in second and third line in terms of how patients did on their previous therapies, what ongoing AEs were critical to take into consideration, how they tolerated first-line treatment, are they maintaining a good performance status, and of course, medical comorbidities are kind of constantly reassessed. So I think big picture, really thinking about it as a map ahead of time and knowing you might have to pivot. But I try to think ahead around what the patient's lines may be over the course of their journey ahead of time rather than taking it at the time of progression. Now that we've discussed how to maximize access to multiple lines of therapy, let's shift our focus to what happens when disease progresses and how we individualize care in later lines. To bring this to life, we're going to hear from Jenna, who will share her experience navigating later line treatment decisions and how those choices impacted her quality of life.
Thank you, Dr. Parikh. I began treatment with chemotherapy and targeted therapy. Midway through an 11-month treatment course, I underwent surgery that included a resection of just over a foot of my colon, 2 parts of my liver, and my gallbladder. After completing treatment, I initially felt well, but follow-up imaging was inconclusive. My cancer later returned in my liver and subsequently spread to my lungs. My treatment was adjusted to include different chemotherapy agents and targeted therapies. I then underwent an additional surgery involving both the liver and the lungs. Over time, this pattern of treatment, temporary remission, and recurrence continued. After another extended course of therapy, in a period of approximately 18 months of disease control, the cancer returned in the lymph nodes around my lungs. At that point, my care team advised that ongoing indefinite treatment would be necessary as the disease was becoming progressively more aggressive with each recurrence. I have now been in treatment for over 8 years, actually going on 9 very shortly. While my family life has continued, ongoing therapy remains a consistent part of my care and also a consistent battle every single month. So,
Jenna, thank you so much for sharing your experience so candidly and openly with us. I think you've really highlighted how treatment decisions and later lines go so much beyond the clinical data. And as demonstrated by you, I think deeply personal and shaped by the quality of life, toxicity, and daily function. Dr. Faki, I think Jenna, greatly appreciate her sharing her perspective. So now would be great to look at the range of later line treatment options available to us based on the current guidelines. Can you briefly mention them to us?
Okay, so for patients who have previously received oxaliplatin, irinotecan, and fluoropyrimidine in combination with bevacizumab or an anti-HFR therapy such as cetuximab or panitumumab, if indicated. In those patients, we are talking about third-line treatments. And third-line therapy can be either biomarker-driven in that situation or non-biomarker-driven. Biomarker-driven directed therapies include targeting BRAF, if not targeted yet, targeting HER2, targeting KRAS G12C, as well as fusions. However, the majority of patients do not fit in that particular group of patients, and those are the non-biomarker-driven group of patients. In that setting, the standard of third line and beyond would include trifluridine, tipiracil, plus or minus bevacizumab, regorafenib, or fruquintinib.
I have a question on that really quickly. So, let's say you have a patient that will endure as much as they can just to get through the treatment, but you see the effect that it's having on them. Would you recommend to the patient that they may want to stop it or pause it for a while and then come back to it? Or would you wait for the patient to then say, like, I've had enough? Or how does that conversation usually go if you can witness it?
It all depends on the patient. If somebody has a lower burden of disease, And that's a patient that can take a break, but somebody who has a major involvement in their liver and stopping 2 months could tip them over into liver dysfunction and deterioration. That's someone that I would counsel that we want to minimize the break as much as possible. This is a long discussion with the patient that has to take into consideration prior therapy. And if you've taken a break and you've seen a quick progression, then you don't want to take another break, right? So I mean, the details are in the pudding here, and I think again the individualization is at the center of everything. Dr. Parikh, how do you apply shared decision making in your clinic when selecting later line therapy for patients with metastatic colorectal cancer? And what clinical factors most influence your choice among later line treatment options?
I think as we're thinking about later line treatment options for patients, really thinking about the whole, again, individual patient and what treatment option not only will optimize their quality of life, but also factoring in convenience for patients. So, as mentioned and in review of the data, there were several options that were oral options only, such as kind of fruquintinib as an option, and then with the trifluridine along with the bevacizumab. Again, an oral option with the bevacizumab being an infusional option. And so really factor in not only convenience for the patients, time to come into the infusion center, but also balancing the side effect profile for each of the patients and each of the therapy options. So, Dr. Fakih, how do you balance modest efficacy benefits with the toxicity when discussing these options with patients? And I think to that end, how do you approach sequencing when you're getting into these later lines settings?
Yeah, thank you. I mean, these are really difficult discussions in this setting with patients, and we all are guided by efficacy data, but we want to make sure that we don't push our patients beyond their tolerance. I think when I look at all these four options that we discussed, I am not convinced that one option is really um, better tolerated than another from the perspective of fatigue, right? If we look at the sunlight data, frankly, the grade 3 fatigue as well as asthenia in that setting, at least numerically, appears to be even lower than fruquintinib or regorafenib. And, to me, what matters the most is not the blood counts, is what the patient feels and how they feel. And so a median progression-free survival of 5.6 months is highly meaningful to me. I mean, I think to have a discussion with the patient around regorafenib and to say that there's a 50% chance that your next scan is not going to be good is not palatable neither to the patient nor to myself. And so if the side effects are acceptable, and I typically really will navigate towards trifluridine bevacizumab unless there's a contraindication such as significant thrombocytopenia in patients, or there's a contraindication to bevacizumab. But in my mind, if there's a contraindication to bevacizumab, there's a contraindication to fruquintinib and regorafenib. All of these have the same class effect from the perspective of anti-angiogenesis inhibition and risks of, say, bowel perforation or acute thrombotic events. And so we typically tend to navigate upon discussion towards trifluridine bevacizumab as the main choice of therapy in the third line setting. But of course, if a patient does not wish to proceed with, IV infusions and or has significant bone marrow toxicities, I do move towards fruquintinib as my other choice. Now, obviously, we're all sequencing treatments, and if one chooses one therapy in a third line setting, it doesn't mean that they cannot use the other one in the fourth line setting. But totally agree with you around regorafenib. I don't think there is much data to support its use beyond fruquintinib, and given such, I am not really sure what the validity of continuing with regorafenib monotherapy would be in this particular setting. After discussing how to select and sequence later line treatments in partnership with our patients, we will now shift focus to how we can optimize those treatments ensuring they are both tolerable and aligned with patient quality of life. To illustrate this, let's turn to Jenna's experience, which highlights the impact of treatment choices on quality of life and long-term care.
Thank you, Dr. Paki. The third time my cancer came back, the framing changed. Now I'm in treatment indefinitely, and after years of strong treatment, I've been on this long term plan for about 2 years, and it still includes chemotherapy and targeted therapy. And the reality is, my treatment is toxic to my body and causes a lot of side effects. So, we did something that I think deserves to be normalized in metastatic care, which was we adjusted the dose so that I could stay on treatment and still have the quality of life that I wanted to have had I not have to go through this treatment with no end date. I lowered my dosage to maintain quality of life because if there's no clear end date, then the plan must be sustainable, not just effective. And I take breaks when I need them because um, And I take breaks when I need them, but only as long as my doctor and I both feel comfortable. And that's shared decision making in action. It's careful, individualized, and rooted in trust, not only the trust that I have in my doctor, but also the trust that my doctor has in me to make well informed decisions about my own care. This is where later line optimization becomes essential. It's not only about what therapy is chosen, it's about how it's delivered and supported so the patient stays strong enough for future options.
Thank you, Jenna, for sharing your take on this. What Jenna here highlights is that sustaining treatment and focusing on maintaining quality of life requires more than choosing the right therapy. It really requires a comprehensive and individualized approach to care. So, Dr. Parikh, let's go back to third-line treatments. When you're using trifluridine and tipiracil, how do you approach dosing and how do you manage hematological toxicities to maintain patient therapy?
So when you look at the toxicity of trifluridine tipiracil, one of the things that comes up very commonly is neutropenia, anemia, and thrombocytopenia, alongside fatigue and some nausea and diarrhea. In terms of the cytopenias, I often tend to do every other week dosing as my strategy. I know Dr. Faki, we've chatted in the past before, and I think if I remember, you said that you tend to use growth factor support, which I think I often will turn to as well, but have found that just every other weeking dosing strategy allows for the management to be a lot gentler in terms of the blood counts, and obviously will delay doses and reduce doses as needed if you continue to get into myelosuppression. When adding bevacizumab to the trifluridine tipiracil, how do you balance the efficacy with the added risk of vascular toxicities such as the hypertension and proteinuria, Dr. Faki?
Yeah, I mean, I think, thank you for that question, but we all use bevacizumab in the first and second line setting, and we are all comfortable with its side effects now. If a patient is on the third line treatment, it means that that patient, if they're getting bevacizumab, that they probably had received it previously for periods of more than 10 months or even sometimes more than 18 months or 2 years, which really tells you that you've already kind of gotten through the potential risks if acute vascular toxicities were going to happen. They would. Now, it doesn't mean that they wouldn't in the future, but really the risk of acute thrombotic event is very low in that setting. For hypertension, I think we have learned how to manage, and again, because these patients had prior bevacizumab, that probably are already stable, but if you need to adjust the doses, you will. Now, proteinuria is something that always comes up. Do we need to check for a UA? And you know, that practice really was based on the clinical trials that led to the approval of bevacizumab. But the reality, I also look at the big picture, and you know, I think patients are scared about, you know, progression and losing a third line therapy when your options are even more limited. So am I worried about a 2+ proteinuria in the urine? I'll be honest, no. I do think it becomes a problem if it's a grade 3 proteinuria. I'm going to move back to you, Dr. Parikh. How do you monitor and manage VEGF-related toxicities such as hypertension and proteinuria when treating patients with fruquintinib in that setting?
So turning to fruquintinib, I think the common things that we see are the hypertension, and it's similarly to what Dr. Fakih mentioned below, or previously with the bevacizumab. I think the hypertension is very easy to get a handle of. I think I don't worry about some mild hypertension. These are patients with metastatic disease. And so even if the hypertension is mild, really doesn't cause too much concern for me. And as patients creep up in terms of their hypertension, I think with the right hypertensive regimen, you can easily get it controlled. I think the similar comments with the proteinuria that we chatted about with the bevacizumab, don't worry about it too much, especially for the 2+ proteinuria. I think the fatigue and hand foot you do have to pay attention to. And I have started just, I think, probably from habit, and the regorafenib learning has started with 2.5. And if it goes well, up titrate to 5 and pay close attention to that over time. How do you optimize dosing and manage toxicity such as hand-foot syndrome and fatigue when initiating regorafenib, Dr. Fakih?
Yeah, so if we if we are using regorafenib, which is really becoming less often now, I think we have to consider the redose regimen, because the incidence of hand and foot syndrome is quite high if you start at the 160 milligram daily dosing. I think constitutional symptoms such as fatigue, which are also seen with fruquintinib, can be seen, and those, if they're severe, may require dose adjustment. So I'm going to move back to Jenna and get her take on the her journey and treatments.
Thank you, Dr. Fakih. So from my experience, a few things really make the difference. First, dose adjustments aren't a setback. They're often what help me stay on treatment longer and maintain my strength. Second, managing side effects early is critical. When symptoms are anticipated and addressed right away, it's much easier to keep going on the treatment plan. And third, having a strong care team matters. Nurses, pharmacists, and supportive care all help catch issues early and keep me functioning day to day. And finally, flexibility, whether it's scheduling or communication, helps me stay engaged in my care without feeling overwhelmed. And at the end of the day, it's about staying well and supported so we can keep moving forward and making the most of every treatment opportunity.
To summarize, optimizing metastatic colorectal cancer care requires a focus on the full continuum, beginning with evidence-based initial management, followed by individualized treatment decisions over time, and delivering therapy in a way that patients can sustain. With this approach, we maximize each patient's opportunity to benefit from all appropriate lines of therapy. Jenna, thank you for sharing your story. It's incredibly impactful. And Dr. Parikh, thank you for your insights and discussion.
This has been an activity published by Peer Voice.